Hi, everybody. Thank you for inviting me to speak today. My name is Lynn Billing. I'm a palliative care nurse at in the Vera building at the Kimmel Cancer Center at Johns Hopkins. I've been here since 1999 caring for cancer patients in a lot of different ways, but for most of my career, I've been a palliative care nurse. And I'd really like to share with you what palliative care is about. As you see in the title, it's not just for end of life. We really want to help patients and families live better and feel better. So what is palliative care? We're specialized medical care for people living with a serious illness. Note that that's not terminal illness, it's a serious illness. And we focus on providing relief from symptoms and the stress of illness. We want to improve quality of life for both the patient and the family, not just the patient. And at the core of this, we're an interdisciplinary team. And I'll explain a little bit more of that later. You can consider us an extra layer of support, and it's based on the needs of the patient, not on prognosis. It's appropriate at any age, at any stage in a serious illness, and it can be provided right along with curative treatment. And this is important. I like to say this, that we're a part of, not instead of, oncology care. So a lot of people are confused, providers included, are confused about what palliative care is and think that it's the same as hospice care. So what's the difference? Palliative care and hospice are all the things that we already talked about: specialized medical care, providing relief from symptoms and stress, improving quality of life, extra layer of support, and appropriate at any age. The difference is hospice is really end-of-life care, and that's defined by hospice and insurance companies as people have that with a life-limiting illness, and their prognosis is 6 months or less in the doctor's best estimate. Also, people are not receiving treatment with curative intent when they're under hospice care. So who are we, the palliative care team? We're an interdisciplinary team, meaning we are multidisciplines. We're doctors, nurses and nurse practitioners, pharmacists, social workers, chaplains. Also included in this, we partner with child life specialists, we partner with psych liaison nurses, rehab specialists, but the core of our team are the 5 that you see here on the screen. What interdisciplinary means is that we don't operate in silos. We are a team and we talk together about patients. We don't necessarily see all our patients together. You might see one of us, you might see 2 or 3 of us, but we talk about you and plan and come up with a care plan for you and your family together. So why us? What makes us different? We worked hard to get where we are by going to school for specialized training or advanced training. Physicians now can be board certified, and here all of our physicians are board certified in palliative medicine. It became a subspecialty in 2006, and along with passing an exam, all physicians must complete a year fellowship. The pharmacists also have to complete a year fellowship. Nurses and nurse practitioners are now, within the last 5-6 years, getting specialized education in school, and that's fairly new. When I started my palliative care career, I sought out education through conferences and special introductory things and certificate programs. And now it's being taught in school, and there are actually fellowships for nurses as well. We also have an advanced certification where we need to take a test in hospice and palliative medicine, and you can see the letters there, and I have that certification with those 4 letters, CHPN, after my name, and I'm very proud of that. Social workers also have to receive special education, and they have a certification exam as well. The big difference between us and other providers that you may know is we have much more time to visit. Our schedules are designed so we can spend time. Providers that you see, oncology providers, they have a very strict schedule, rigorous schedule that they have to keep, and often aren't able to spend as much time as they would like with you. And ours are designed so we can spend a half hour, an hour if we need to, whatever's needed, to really sit down and go through things and develop a relationship. So what kinds of patients do we see as palliative care providers? We see patients experiencing the physical distress of pain, loss of appetite, weight loss, bowel issues, fatigue, nausea and vomiting, some dyspnea, shortness of breath, and sometimes confusion and delirium. The things we see most often, and I highlighted fatigue here because it is probably the #1 complaint. Also pain, and the last thing is loss of appetite. In my experience, these are the 3 most common things I see as a palliative care provider. It's not just physical distress. We also see patients with emotional distress, spiritual distress, questions, confusion, what's going on with my treatment, what are my options, and patients and families that are really facing difficult decisions. So what can we do to help? As I said, we're really specially trained and have expert and aggressive pain management techniques and ideas other than what's the norm. We also are experts at managing symptoms of not just the disease, but the side effects of treatment. We help by educating. Knowledge is power, and we want you to understand what's going on, understand what we're telling you or what's being told to you by other providers. We advocate for you. We advocate with your providers, with other physicians, with other disciplines to get you the help that you need. We're pretty good at facilitating discussions. Sometimes it's hard to have conversations with each other, people in your family. I find that folks often try to protect one another. A wife tries to protect her husband. They don't want to talk about things that might be scary. So we're helpful in facilitating those discussions, as well as providing support emotionally and spiritually for those hard things that are going on. We're good at coordinating care too among the specialties, among your providers. We don't just come and see you, we talk to your providers and let them know what we think and let them know what's going on and what our recommendations are and who else might be able to help. We also talk with you about advance directives. We can explain what they are, why they're important, what you need to do to have an advance directive. And I have one. I highly recommend that everybody has one. This isn't something just for people who are facing end of life. It's for people who want to be in control of what end of life looks like when that happens. So how do we do all of these things? I think the biggest thing we do is ask a lot of questions. We really feel like detectives sometimes. We investigate. For example, if somebody's in pain, we just don't say, oh, you have abdominal pain, take this drug. We ask a lot of questions about the pain, where it is, what it feels like. There are different kinds of pain, and there are different kinds of pain medications. We want to figure out the right thing for the right pain. We also want to sit and talk things through with you. Sometimes some people ask a question, a yes or no question, and very little information is exchanged that way. So by sitting and talking and asking questions and listening, we find out a lot more and help you think things through. We also want to have discussions about, these are my words, the heavy, deep, real things. The things that are worrying, worrisome. What if there comes a time when things aren't going the way that you're hoping, can you think about that time? Can you think about what might need to be done, what you need to think about? We can help you think about those things. We don't push you into thinking about things. We want to meet you where you are and help you have the conversations and help you think things through, so we avoid crisis management. We all have crises in our lives, and we know how emotional things are around crises. It's much easier to talk and make decisions before that time. The other big thing we do, I think, is provide education, because we really believe that knowledge is power. We discuss a lot of burdens and benefits. And when I talk about that, I talk about treatment. What's the burden of this treatment? What are the side effects? What are the benefits of the treatment? Same thing with pain medication or other medication or any kind of intervention that might be going on. What are the burdens and benefits, and what's the right thing for you? Often you have conversations with your providers too when they're talking about they're talking in medical jargon, or alphabet soup as I call it. Everything is explained in letters these days. We want to help you ask the right questions. I hear a lot of oncologists explain treatment options in terms of response rate. Well, there's a 10% response rate with this certain regimen. What does response rate mean? That's one of the things that we want you to ask. Does it mean that the tumor shrinks a little bit? What are the burdens of that treatment? What kind of life will I have while I'm getting that treatment? So knowing those answers will help you make the right decision for you and your family. And again, the big thing we do is spend time and listening. Listening is a hard skill to learn, and after being a nurse for 25-ish years, I'm still learning it. It's very hard for anyone to just sit and listen, but it is a skill, and we want to listen to you and understand what you're going through and really help with the things that you want us to help with. We're going to talk a little bit throughout this about Mr. Q, who's a patient who's 68 years old. He was recently diagnosed with colon cancer, and at diagnosis had no known metastasis. The goal of chemotherapy, they're starting today, is to cure, to shrink the tumor, and then have a surgeon take the tumor out. When I meet Mr. Q, he's worrying about side effects and very anxious about what might come. He also is complaining about a poor appetite and losing weight. So I sit down with Mr. Q and his wife, and they tell the story, and I listen. I hear the story of how he was diagnosed and how he's been feeling and how he's been losing this weight and how hard it's been on both of them, and also why he's so worried about the side effects. His mother-in-law died of pancreatic cancer several years ago and experienced a lot of side effects, and he saw that and is very concerned that he will have those same issues. So what I did was sit down with them and talked about the anti-nausea plan. It sometimes is very complicated with chemotherapy, and there are different drugs that need to be taken at different schedules. And so what I did was help explain what that schedule looked like. And I also reassured them that if what we're doing, if this plan was not working, that we have other options and we would be aggressive and change that until his symptoms were under control. Also, the appetite. We hear that a lot, and that can be a huge, huge problem, especially for the family. So we provided education about how this is normal. Unfortunately, we hear this from almost all of our patients, and we talked more about it and provided strategies. So let's talk about appetite for a minute. Why are patients with cancer so struggling so much with appetite? And for Mr. Q, it was probably the cancer itself at this point. Cancer can cause chemical changes, hormonal changes in the body that affect appetite and cause taste changes. So things that have always tasted wonderful, favorite foods, kind of taste weird now, and people lose their appetite for that. Also, tumor can affect digestion, and it can cause diarrhea, constipation. In this case, Mr. Q was having some issues with constipation. Other things that can affect appetite are the treatment itself, the drugs that we give, radiation therapy, usually with colon cancer patients or GI cancer patients. It's in the area of the abdomen, the intestines, so it can affect the digestive system as well. Immunotherapy, then some of the newer treatments also affect appetite. Depression and anxiety are things that steal appetite away. Nausea, of course, when you're nauseous, you can't eat. When somebody's in a lot of pain, pain kind of takes over and it becomes the focus of what that patient is going through, and it's difficult for the patient to eat when they're in pain. Ascites. Ascites is fluid that builds up in the abdomen, and with a lot of patients with colon cancer, with pancreatic cancer, this becomes an issue. And having the fluid in the abdomen causes pressure. It takes up room, so it causes pressure, pushes up on the stomach, so there's not enough room in the stomach to hold food, and people aren't hungry or they get full very quickly. Tumor in the abdomen can do the same thing. And there are a lot of medications that all of us take, any of us take, that can really diminish appetite. So these are some general strategies for helping to get more food in and feeling good about it. I'm not a nutritionist, but these are things that can help everybody. Small, frequent meals. Try to get away from the 3-meal-a-day idea and just graze like a sheep all day. What you do get in, try to make sure that it's high in calories and has protein. Protein is what you need for energy. You want to avoid cooking odors. Try to stay out of the kitchen while food is being cooked. And if you family members can serve small portions and serve food at room temperature. Small portions is really important. So many people tell me that their daughter brings them a plate of something, spaghetti, and it's a full plate, and as soon as they see it, it turns their stomach off. They just can't even think about eating it. But if it's a very small portion, if it's a half a sandwich, even a quarter of a sandwich, it's a lot more doable and a lot more appealing. Strong flavors too are difficult. Very spicy foods. These kinds of things also are, people tell me, aberrant. They don't like them. So try to think bland and try new things. So their taste changes. Things that you've always loved may not taste good, but maybe things that you've never liked all of a sudden do taste good. And just a word about appetite stimulants. We do have some appetite stimulants. Some work well, some not so well, but it's a good thing to talk to your providers about whether or not that would be the right thing for you. These strategies hopefully can work really well without an appetite stimulant, but sometimes that's the right thing to do. And for the family members, remember, this isn't mind over matter for the patient. It's not something they're not trying to do. So offer frequently, encourage, but don't nag, as my mother would say. And patience, you can't get mad at the family for offering frequently and reminding and trying to encourage you. We don't want that battle to start, and it can really be a battle, and it's really bothersome to families. So let's get back to Mr. Q again. So I see him again. He's had 2 cycles of chemotherapy, and the disease is stable. But the doctor, the oncologist says, let's just do one more cycle before we get to surgery. I want to see a little more shrinkage there. So Mr. Q is having extreme fatigue at this time. He started with a little fatigue, and now from the chemotherapy, it's adding up. He's had intermittent nausea and vomiting, as he was worried about. It wasn't as bad as he thought, but it's still there. And when I see him this visit, his wife had to work. So his friend dropped him off. So Mr. Q and I are talking, and he shares that he's really worried about his wife. So what we did, we reviewed his nausea medications and schedule, and he was doing everything exactly right. I wanted to make sure of that first. And because that wasn't working, we adjusted the regimen. So for this upcoming chemo that he was getting, he was doing something a little bit different, and the nausea and the vomiting was much better controlled. And in fact, he didn't vomit. We were able to have a long discussion about fatigue, and it was really bothersome to Mr. Q because he had been an avid runner and was no longer able to run because he was feeling so tired. We also talked about the goals of treatment a little bit, and he was telling me about his hope for surgery and the cure that had been discussed. And we talked a little bit more about his wife. He was really worried about her because she was working hard, she was worried about finances, and she was worried about him. And he thought she probably wasn't sleeping really well. So I contacted our palliative care social worker and explained things to her, and she contacted his wife. And she really talked through things with her and found out how worried she was about the patient and finances, and the social worker was able to really provide some counseling and emotional support and some resources for her to explore, and she stayed in touch with her frequently. So let's talk a little bit about fatigue, and I think this is probably universal among cancer patients. It's caused by a lot of different things, and first, the cancer itself. Cancer cells are metabolizing at a much higher rate, so they eat up our energy, they eat up calories quicker than our normal body cells. Cancer treatment, of course, can really rob energy. A lot of medications can too. We give medications for pain and nausea that make people sleepy, so that's another layer of this. Chemotherapy, sometimes disease, lowers the blood counts, and in particular for fatigue, it can cause anemia or low red blood cells, which really can zap people's energy. When people aren't feeling good and they're going through treatment for cancer, often the sleep-wake cycle's disturbed, so they're not getting the rest that they need. Pain and other symptoms are stealing energy away. And again, depression can really take energy away. People who are clinically depressed often have trouble sleeping, and the same with anxiety. So some general strategies. Believe it or not, there's been a ton of research done on this, and the best evidence that we have to help fatigue is exercise. It's kind of counterintuitive. How do I exercise if I'm so tired? But what can you do? In Mr. Q's case, he can't go out and run 3 miles, but he can walk. And he might not be able to walk 3 miles, but start slow and build up and push yourself gently. And we talked about walking to the mailbox, walking around the block, taking the dog out for a walk in a park, and try to build up. Even if you're feeling really horrible and sitting on the sofa or sitting in a chair, you can exercise even when you're sitting by doing leg lifts, ankle rolls, lift soup cans, lift weights while you're sitting there. Just keep those muscles moving. The other thing you need to do is conserve your energy. I like to say you wake up in the morning with $100 worth of energy, and you need to decide then and there how you're going to spend it. So if you have something you want to do later in the day, you want to go shopping, you want to go visit a friend, you want to go out to lunch, you want to play with your grandkids, you know that's going to take up a bunch of that energy, $50, $75 worth of energy. So you need to save up until you are ready to use that energy. Rest before you go out, or plan time to rest between activities. Nutrition, again, it's so hard. We talked about how hard it is to eat, but you need nutrition for energy to counteract fatigue. So again, the nutrition that you can get in, try to get high calories and high protein. Sometimes the medication that you're taking can be adjusted. So if things are making you tired, let folks know, let us know, let your oncologist know that you're really tired, and maybe we can make some adjustments and trade a drug off for another one that wouldn't make you as tired. And we need to stay on top of your symptoms. If we're not doing a good job managing your pain or other symptoms, we need to know about it so we can be more aggressive. So back to Mr. Q again. The final CAT scan, unfortunately, before surgery, revealed that he did have some liver lesions, and surgery was no longer the right option for him. So the goal of treatment changes. This is no longer curative intent. The oncologist sat with he and his wife and talked about additional options, and they opted for continuing second-line chemotherapy. The wife starts talking about how sad she is about, I'm going to have to cancel that cruise that we had planned. And Mr. Q also worries about worsening side effects. So let's talk about goals for a minute. This is a scenario where the goals are shifting, and they often shift. Things that you should think about, things that you should talk about. What are your goals? What are you hoping for? Cure is always something that's on people's mind. When the goal shifts, what else are you hoping for? Better quality of life? Longer life? Or is comfort the most important thing? Or are all of these things the most important? What we can do to help too is clarifying goals and helping you ask the right questions. What is your prognosis? Do you want to know what your prognosis is? How much information do you want? And how do you talk with your physicians about that? Talk with your physicians about options and ask the right questions. Again, sometimes we talk in alphabet soup and we talk about response rates. What does that mean? You need to be able to ask the questions. I think sometimes we sit in doctors' offices, all of us, and they're talking to us, and we're trying so hard to concentrate on what they're saying and understand what they're saying that we miss a lot. So we often recommend take a tape recorder or write things down, write questions down before you go. We can sit and talk about ways to talk with the surgeon, with the oncologist about benefit versus burden, that kind of thing, and to help them understand what your goals are. So back to Mr. Q. He started the chemotherapy. Before he started, we started a more aggressive regimen to prevent nausea. And we spent time talking about the frustration and anger because of the shift in goals. The emotional distress was really playing a big part on how they were dealing with this. The goal of chemo from the oncologist's point of view is now to control cancer or prolong life. But what we wanted to focus on here were what Mr. Q's goals and hopes were. And when he talked with us, or talked with me, what he's hoping for is time with family. Wants to feel better and was really concerned that what if this makes me feel worse? What's that going to mean? So I encourage Mr. Q to talk with the oncologist about the plan for the cruise. There are options around this. This was something that was very important to them. It was their 25th wedding anniversary, and they had this plan for a long time. So these are the kinds of things that the oncologist or that we need to know. Something important to you, how can we make that happen? One of the things that happens often is a chemo holiday. okay, the cruise is planned for this time. Let's do chemo for a month before, give you a break for a month, go on the cruise, and then we'll pick up where we left off when you get back. Also, we, as palliative care providers, want to make sure that you have a really good symptom management regimen before you go on that cruise, and knowledge to know if this happens, if that happens, take this, take that. You have a plan, and you have optimum symptom management so you can stay well on your vacation. So over time, Mr. Q and I, we really developed a relationship, and there was a lot of trust there. That's very important, I think, in oncology care and palliative care, is to have that continuity, to go along on this journey, if you use that word, and to have discussions along the way as things shift, as issues come up. We were able to talk about his fears. He was very reluctant to talk about that at first, but he was able to talk about his fears and talk about the what ifs. What if this chemo doesn't work? What do I need to think about? So we talked things through. I learned that spirituality was something that was very important to him, and our chaplain visited and had some really wonderful conversations. Our social worker continues to support he and his wife. We talked about advanced directives, and both of them completed advanced directives, and even more important, they had the conversation about that. They talked to one another about what they would want, what they wouldn't want. And by continuing to see him, I continued to help manage his medications, adjust things around according to what was going on. So what this did, hopefully, was to help Mr. Q maintain a sense of control. We talked about a time when hospice might be appropriate. It's a hard conversation to have, and actually Mr. Q brought it up. He was ready to hear and think about that what if, and I was able to explain what hospice was and what that would look like for him and his family. Because of these things, we've been able, hopefully, to avoid crisis management. Through all this, Mr. Q hasn't been hospitalized, so he hasn't had a crisis, and we're hoping that that will continue. And there's been ongoing counseling with the social worker, and she's facilitated a family meeting with his older children and his wife, so they could all talk about all of these issues together. So the other thing about my job that I love is my patients teach me things, and what Mr. Q has taught me over time is how hope can change, and how the things he was hoping for at the beginning of his cancer therapy changed as he started to go through therapy. He also taught me that work is important. His work was important. He continued to work, maybe not full-time, but part-time. And for me, I always thought, well, if you're not feeling well, that's the first thing you shouldn't do is work. But that was something that was very important to him. So we talked about how he could continue to work through his cancer therapy. And the other thing he taught me was the strength of a strong spiritual connection. That has helped him and his wife through many, many difficult circumstances in their lives, but especially through this time. So I just want to do a rewind. Let's go back in time and have another scenario for Mr. Q. Go back to the time when he finished that first round of chemotherapy and had the scan, and it didn't show any signs of metastasis. He had successful surgery and was in the hospital, but had very severe pain after surgery. So the palliative care service knew him already through discussions with me, and Mr. Q was consulted, and our palliative care nurse and pharmacist on the inpatient side visited and recommended a different pain regimen and also added a bowel regimen. So on the day of discharge, we heard that he developed nausea from his pain medication. And I put a question mark there because that's what we hear a lot. Always the pain medication is blamed for things. So the palliative care team went and talked with him and did recommend a pain med change. But they also, through investigation, discovered that he hadn't had a bowel movement in 3 days, which the team wasn't aware of. So palliative care recommended an additional laxative, a stronger laxative, and he was able to have a bowel movement and go home the next day, no longer constipated, and his nausea resolved, which was probably at that stage related more to the constipation than it was to the pain medication. And his pain was at a tolerable level when he left. So in summary, palliative care is holistic care. We look at the patient. We look not at the cancer. We look at the patient who's experiencing cancer and their family and how it's affecting all of that. Palliative care improves quality of life, helps regain and maintain a sense of control. And it's not just for patients, it's for families as well. And we encourage patients and families to think and talk about the future and talk about the plan for the what ifs. I want you to know that palliative care is not always offered, and if it's not, request a referral, request a consult, or maybe you need to insist on a consult. Still, there's a lot of misconceptions about what we are and what we do, and patients aren't ready, the doctor's not ready, but hopefully through this talk you can see that we can provide help along the way no matter what's going on. Here are a couple resources for you. If you Google palliative care, all of these will come up, and they have a lot of information about palliative care in much more detail. And life might not be the party that we hope for, but while we're here, we should dance. And that's what palliative care wants to do, is to help you dance. Hi, everybody, and welcome. I hope you're enjoying the conference, and I hope my video has been helpful to you. We have some questions that have been posted earlier in the day, and hopefully I addressed these in the video, but I'm going to review them just in case and maybe elaborate a little more, but I welcome any questions that you might have or any comments as well. So the first question is, how can we help those that need palliative care not automatically assume it's hospice care? And hopefully you have gotten a good idea of what the definition is. I think the easiest way to explain that is palliative care is the big umbrella, that a lot of things come underneath that umbrella, hospice being one of the things. And I just want to stress that we help with symptom management, emotional and physical symptoms during treatment, during curative treatment. Hospice care is a part of palliative care in that it is end-of-life care, focusing on the same things: comfort, physical symptoms, and emotional symptoms. The next question is, doctors seem very hesitant to tell patients we are at the end of the line. Many people take treatment until they die. There seems to be a disconnect between doctors who treat and hospice. Why? Well, if we had another hour, I could explain the many reasons why, but I can say that this is common, and fortunately, it's become less common in the last 5 years or so. I think a lot of doctors aren't very good at this, and they are afraid of taking patients' and families' hope away, so they tend to not be as aggressive or as upfront with what's really going on. Other doctors wait until there's a crisis, and they have to have that conversation instead of it being a slow, ongoing, easy conversation to lead up to that. I think I answered that, and if not, please post another comment. How can advocates help patients explore the idea of hospice? By undemonizing it, by explaining that hospice does not mean they're going to die tomorrow, that hospice is something that's part of a lot of patients' journey, and it's very helpful at the end of life to improve quality of life, even at the end of life, and not just for patients, but their families too. Something that's been going on in our area for the last several years are hospice informational visits. So when we are starting to think that a patient's going to need hospice in the next months or weeks, we advise to have a hospice informational visit where the hospice folks actually go to the house and have the conversation and explain everything they do and how it works. Just to make it a little less scary when the time comes, and it empowers patients and families to decide when they are ready. We often, as providers, the oncology providers, really encourage this and encourage hospice to start as soon as possible so they can really benefit from their services. Would you suggest palliative care early to give patients comfort during treatment? Yes, yes, yes. And I hope you got that from this video, if nothing else. The best way to provide palliative care is when a patient starts receiving treatment. And this doesn't matter whether it's curative treatment or just palliative treatment, but the sooner we get involved, we can nip problems in the bud, prevent them from becoming bigger problems. And we have time to build a relationship with patients and families so we can have the difficult conversations, so we become a trusted member of the team. Sometimes folks are a little hesitant to ask their physicians questions about prognosis, questions about what's really going on. And we might be the safer people in that to talk about or to facilitate a conversation between the patient and family and the physician. The next one is, what's the top myth you wish you could keep patients from hearing? And that is that palliative care and hospice are the same thing. That palliative care does not mean you're dying. And I've had that happen many times as a palliative care nurse. We're referred, we're consulted, and I go into a room and they see the word palliative on my lab jacket or ask where I'm from, and they hear the word palliative and they get scared and they say, oh, I must be dying, or does that mean I'm dying? And so we need to really help people understand that the P word, palliative, is not a dirty word, that we are there to be helpful and meet patients where they are, not to push anything, not to try to get people into hospice. That's not what we're there for. We're there to support and really promote their way of doing things and encourage them to think about their goals and sometimes shift their goals when the time is right. The last one I see on here is, I see so many people suffer without support. They wait until the last 10 days of life to get hospice care. When can a patient ask for hospice? When they have 6 months to a year left? A patient can ask anytime. What happens in hospice is typically the physician has to sign a document certifying that in their best opinion, the patient has 6 months or less to live if the disease plays out its usual course. So it's not that the patient needs to determine that, and there doesn't need to be that order to have a hospice informational as well. but I encourage anybody anytime to call their local hospice if they have questions, if they want to talk to them, if they want to be proactive and be prepared for when the time comes. I think that is the end of the questions. My friend Alex is helping, and I don't see any more questions that are new. So I really hope that this video really helped and helps you understand palliative care and helps you understand how we can help. And sometimes you need to ask for it because physicians and other providers still are not sure and don't understand what we are about themselves. So it doesn't hurt to ask for us. Whenever I see a patient, I make sure I discuss how things went with the physician. I don't recommend medications or anything directly to the patient, but I offer up suggestions. So I am part of the team. I talk with the oncologists, the nurse practitioners, to talk about what is going on and make decisions together. So I am not practicing in a void. I am part of the team, as we all are, and we are a team as well, but we never practice in a void. And that's the cool thing about palliative care, is you've got another team of people on your side, an extra layer of support. So please, if we're not recommended, if you think we might be helpful, please advocate for yourselves and ask for a palliative care consult, and we're happy to see you. Alex, I don't see any additional questions at this time. So I think I will say, please contact us if we can be helpful. If you post any comments after the conference, I'm sure they can get them to me. But I wish you all the best, and I'm really glad that you're participating in this to be advocates for yourself and get all the information, because knowledge is power. Thank you, and I wish you the best. Take care.